All right, it's my distinct pleasure to turn things over to Nicole. Nicole?
Thank you so much, and welcome to everyone joining the call today. We are so grateful that you are dedicating this hour to be here with us today when we discuss the economic side of the COVID-19 pandemic and its repercussions and impact on our communities. I'm Nicole Aiello-Sapio. I'm the Executive Vice President for the Eastern States region of the American Heart Association, one of 5 regions serving communities across the country. In the Eastern States, we serve 13 states and the District of Columbia, extending from Maine to Virginia. It's wonderful to see that so many community leaders from across a wide geography of our country are able to come together virtually today. And so grateful to our moderator and all of our panelists who are sharing their time and their expertise throughout this program. I want to acknowledge my colleagues, Jeremy Beauchamp, Executive Vice President of the Southeast region of the AHA, and Kevin Harker, EVP for the Midwest region of the AHA, who are also a part of today's program. We'll hear from Jeremy and Kevin a little later. Before we begin our discussion today, we will pause to acknowledge recent events. Please watch this video from our CEO, Nancy Brown, and our AHA National Board Chair, Bert Scott.
Like you, I am heartbroken by the tragedies that have taken place across our country. The memories of George Floyd, Breonna Taylor, Ahmaud Arbery, and far too many others remain with us, and our hearts go out to everyone, everywhere who is grieving and searching for justice. The American Heart Association denounces senseless acts of racial violence against individuals and unnecessary violence in our communities. As a nonprofit healthcare organization, we are taking a stand on social justice issues because it's the right thing to do and because there is scientific evidence supporting the link between social justice and health equity.
Racial disparities in heart disease, stroke, and other chronic conditions exist and are well documented. African Americans are also more likely to be uninsured. There is also scientific evidence that African Americans' physical and mental health is negatively impacted by the inequities that exist. Add this to the fact that in the midst of a global pandemic and given barriers to health that exist, African Americans and other people of color are disproportionately impacted by COVID-19.
The American Heart Association has championed health equity for all people for nearly a century, and we are more determined than ever to eliminate racial and class disparities. We will redouble our commitment to overcoming barriers to health and to addressing social inequalities.
We must stand together as a relentless force for a world of longer, healthier lives. That is our mission, our contribution to a more equitable society.
People are counting on us like never before. We will listen. We will drive change. We will be relentless. Thank you for your support, and thank you for listening.
I know that we at the American Heart Association, we all echo the sentiment shared. People are counting on us like never before. We will listen, we will drive change, and we will be relentless. Our focus together today is the critical need to foster health and well-being in Appalachian rural communities, particularly amid COVID-19, and how economic changes play a significant role in outcomes. Long before the pandemic, systemic challenges have contributed to disparities and impede some from living longer, healthier lives. Persons in under-resourced communities have a higher risk of developing heart disease, the #1 killer of all Americans. Approximately 50 million people in the US are at a higher risk for cardiovascular disease because they lack the most basic needs: healthy food, clean air and drinking water, quality education, employment, and housing. That means approximately 50 million people in the US are forced to make trade-offs between paying rent and purchasing medications, healthy food, and medical care. That is why we're here today. I'm so pleased and honored to now introduce today's moderator, Darby Turner. Darby is an attorney and partner at the firm Bingham, Greenebaum and Dahl LLP in Lexington, Kentucky. I've had the pleasure of working closely with Darby as one of our most treasured leadership volunteers for many years. Darby is a past member and chair of the former Great Rivers Affiliate Board of Directors and longtime dedicated volunteer and supporter of the American Heart Association. Darby is also a longtime volunteer with many other community and nonprofit organizations and currently serves as chair of the American Heart Association Midwest Region Board of Directors. Welcome, Darby, and I'll turn it over to you.
Thank you, Nicole. It's so good to hear and see you again. And I'm very glad to be here today with all of you. You know, Appalachia and Eastern Kentucky particularly is very close to me. My Lexington basically serves as kind of the service center to Eastern Kentucky, but my grandfather came out of a small town called Drift in Floyd County, deep in the coal country, over 100 years ago. I came to UK, and that's so we've got ties that extend back into there. It's important to focus on the Appalachian and the rural communities. Let me introduce our speakers that we're going to have today so we can get right to it. Logan Thomas is an economist with the Washington, D.C. based Appalachian Regional Commission. Since joining the organization in May 2016, he has taken part in a number of research projects examining socioeconomic issues in the Appalachian region, including creating a culture of health in Appalachia, disparities, and bright spots. Our next panelist is Jean Rykaczewski, and she is the Executive Director for West Alabama Food Bank. She has served in that role since 2016 and led a failing FA food bank into a successful one, delivering more than 5 million pounds to those in need. Brock Slaybach is our next panelist. He is a Senior Vice President for Member Services at the National Rural Health Association. Brock joined the NRHA in 2008. He has administrative responsibility for all areas of member services, including membership, communications, and meetings and exhibits. Let's begin our discussion by going to Logan first. Logan?
Oh, thanks, Darby, and thanks to the American Heart Association for letting me take some time to share my thoughts regarding what I think how the economic fallout from COVID-19 might affect the Appalachian region in particular. So let's get right into it. Next slide, please. Keep going, one more. Okay, so just so we're all on the same page, how ARC defines the Appalachian region, parts of 12 states and all of West Virginia. So from up New York in the north to Mississippi in the south, 420 counties, a little over 25 million people. So about 8% of the country's population. Next slide, please. And so some of the underlying health conditions that make the population more at risk for COVID-19 complications, as Nicole just touched on, higher morbidity, including heart disease, other COPD, more obese population, also an older population, so the median age is older throughout the region. Also the share of the population 65 plus, I think it's like 18 point something percent in Appalachia compared to 16% in the country as a whole. And also just the number of healthcare facilities. I think we've all probably read articles about the closure of rural hospitals throughout America. So this is rural America. I think we've seen something like 120 rural hospital closures the past 10 years, 34 in the past 2 years. And those that are in the region sometimes lack the capacity to handle kind of maybe an onslaught that stemming from a coronavirus outbreak in rural communities. But we're turning to now more kind of the economic perspective of things. So next slide, please. All right, so it's, seems commonsensical for me to say this, but we're entering a period of significant economic decline right now. Just yesterday, the National Bureau of Economic Research kind of made it semi-official, saying that the 128-month period of economic expansion came to an end in February. Just yesterday, the World Bank released a report saying that we're now entering a period of economic decline unrivaled since the end of World War II. So there's no doubt that we're entering into a period of economic distress. How long this lasts, what it'll look like, I think remains to be seen. But we can make some assumptions based on underlying economic conditions that this may have a disproportionate impact on Appalachia. And one of those things includes that the lower incomes throughout the region. 83% of the US figure in terms of median household income. There was a survey released by the Federal Reserve Board called the Survey of Household Economics and Decision Making just last month that said, I think this was polling people in mid-April, that 39% of households making under $40,000 had experienced a job loss already due to COVID-19, compared to 19% for households making between 40 and 100,000. So there is a discrepancy there in terms of how the economic fallout has already impacted folks throughout the region, throughout the country, based on income levels. Next slide, please. I think one more slide, please. I think I can talk with this one anyway. We can catch up later. So with the lower education level, so point number 2, folks with lower education tend to have jobs that you cannot telecommute from. So I think maybe a lot of us on this call are fortunate enough to have jobs that we've been able to adjust as needed. But there's a Pew analysis that came out a few months ago looking at CPS data, found that 22% of high school grads had a type of job that they could telecommute from. Whereas this was 62% for folks with a bachelor's degree or higher. And the lower levels of broadband throughout the country just further exacerbate these issues. So even if you had a job that you could telecommute from, you might not have that opportunity because either you lack the resources at home or your community doesn't have broadband access. And just a quick note are people seeing the slides, or is that just something with me that I'm no longer seeing slides?
Hi, Logan. Our internet, our host who had the slide deck has lost her internet. Great. We got
okay. Well, perfect timing for the broadband access issue. I think we're seeing it play in real time. That was not planned, everybody. I wish I could claim that. Okay, so maybe next slide then. We're back up. Okay, great. So just a current snapshot of where we stand in terms of COVID cases. So the region has been fortunate so far in terms of per capita, hasn't been as impacted. We've seen typically metro areas have been hardest hit. That is changing now. There are pockets, of course, throughout rural America that have been hit hard. But as a whole, the region has lower cases. Whether this will remain to be true moving forward, I'm not an epidemiologist. I'm not a public health expert. Remains to be seen. But we do know that the unemployment rate is slightly higher in the region than the country as a whole. It tends to be that way. The gap isn't quite as large as what we were kind of expecting. These are not seasonally adjusted numbers. Next slide, please. I think it breaks down a little bit further. Okay, so I should note on unemployment, I think it's slightly higher in rural areas, something like 15.9% in rural Appalachia, 17.1% in distressed areas. So the places that are already at experiencing distress, just this downturn has further exacerbated those issues. Looking back, this is a kind of an overly simplistic look at how the region had dealt with a past economic downturn. So heading into the Great Recession about a decade ago, so you had growth that lagged the country as a whole, but there's only about a 2 percentage point difference there. But then during the recession, the region lost more jobs than the country as a whole. And since then, just further, there's been a significant gap there between employment growth at the country as a whole and the region. Next slide, please. And this is shown out based on metro status. So large metro areas saw growth comparable to the country as a whole. Then you look at rural areas that actually saw no economic growth during that 5-year period. So basically what I'm trying to say here is that the region has the type of economic characteristics that make it more prone to economic downturns. This is based on both past experience, and then there is research that's shown that typically disadvantaged groups experience downturns more seriously than others. And we're seeing that play out already, looking back at the SHED survey based on job loss and household incomes. We're seeing that play out. Next slide. One quick note I'd like to point out is that, we talk about rural America. Sometimes we mistakenly think of a monolith, but there are differences, of course, based on geography. And so rural Appalachia compared to the rural non-Appalachian part of the United States. So rural Appalachia is actually, it's older, it's poorer, has lower education levels, much lower labor force participation rates, which just further complicates these issues related to COVID-19. And I think that those are important to keep in mind. Next slide. So kind of thinking ahead now, some reasons for pessimism, as I mentioned, the underlying health and economic conditions, and also kind of the long-lasting impacts. Again, there's past research that's shown that, disadvantaged communities, groups of people tend to experience the downturns more seriously, and it takes them a longer time to get back up to where they were prior to that downturn. And then also, I've been talking entirely of kind of the working age population, but thinking of childhood education and kids that go to schools that maybe lack resources. And this has represented a significant pause, for lack of a better word, in terms of their educational journeys as elementary students, as high school students. And so how that will play out, not just now in terms of childhood education outcomes, but later life outcomes is a concern. But there is some reason for optimism, I think. Next slide, please. Again, I want to emphasize, I'm not a public health expert, but the rural nature of the region very well may protect it from spread of the virus. I can't say that for certain, and I think it remains to be seen if that would be the case. That is certainly a hope. I think the tourism industry is going to change significantly after this. I was reading an article the other day. In April 2019, TSA screened, I think, 70 million people in U.S. airports. In April 2020, that was 3.2 million. So we're not gonna stay at 3.2 million, but I don't think we're gonna get up to 70 million anytime soon. So you think of the population centers nearby Appalachia. Airbnb came out and said that there's been a significant increase in domestic bookings and within 200 miles of the home of the person making the booking. So there might be a huge increase in terms of kind of just domestic tourism and whether Appalachia can take advantage of this opportunity. And there has been a trend towards the type of activities and in places that Appalachia has in terms of kind of outdoor activities. Whitewater rafting is huge. So just a matter of how long that, if Appalachia is able to take advantage of that and how long it'll last. And that's, of course, assuming that everything is done safely. And we're not talking about, the spread of the virus. We're just talking about safe tourism. And I think with 3 and 4 that, there has been so you have reallocation of jobs between industries. I think there's going to be significant impact there. But in terms of relocation, I'm not sure if this will be like a great migration away from cities, but I think there will be to some extent where businesses and people are going to reconsider, is it worth paying the high rents, both at a personal and business level in terms of office space and housing in these large cities when we've kind of proven over the past few months that many jobs can be done remotely, like many of us are doing now. And so, it's kind of, I think we're on that trend for the past 10 years, and I think we're heading in that direction. But now I think we've kind of hit the fast forward button. So I think there will be a reallocation, relocation of labor. And one more slide, please. With all that said, it's going to be interesting. If we're recording this, so if we watch this a year from now, whether we seem too rosy, too pessimistic about everything, and so much of that revolves around medical advancements related to treatment and possible vaccination. And so also the spread of the virus. So right now the region's fared well, but whether that remains to be seen, I'm not sure. How long policies and guidelines regarding distancing remains in place, I'm also not sure. But I think the really interesting thing will be how much this impacts all of us. We've all had changes that have taken place in our lives, both in terms of professional, personal. So moving forward, there's something called kind of the paradox of thrift that does concern me. So what's good for the household, what's good for the individual, saving, maybe not spending as much because you're always worried about the next pandemic, the next economic downturn that leads to a decline in overall aggregate demand. So that's another thing to keep in mind. And then also fiscal and monetary responses. are going to be a huge factor. Congress passed, the stimulus, March, April. Time doesn't mean anything to me anymore. I forget when exactly, and what remains to be seen from them, I don't know, but it'll obviously have a huge impact on things. And I apologize, I think I've run over a little bit, but Darby, back to you, and thanks again for the opportunity, everybody.
Hey, Logan, thank you so much. Great presentation. Now for some insight from the front lines of food insecurity, let's turn to Jean. Jean?
Hi, thank you so much. Yes, we've been definitely frontline workers, and this COVID and the food insecurity level has hit so many people that have never experienced food insecurity. In our area, we have a lot of automotive plants, we have chicken processing plants, we have 3 universities around our area, plus 2 community colleges, and all of those stopped. So for us, getting food to people who are food insecure was very paramount to what we do. A lot of people don't realize that when schools shut down and they stop serving children over the summer, then food banks step in and provide summer feeding. And so we had to switch gears very quickly to adapt to that and try to make sure the children stay fed. So can I have the first slide, please? You can see we cover 9 counties of West Alabama. In that area, you can see we have a lot of the dark green areas. We cover 8,000 square miles in our area. And out of the state, we have 5 of the top 10 poorest counties. We have some counties that are close to 42% poverty rate, which makes it very difficult for us to serve. The interesting thing about this pandemic was we saw people that had never experienced that before. When you have both family members working at an auto plant or both families working at a university, and all of a sudden the paychecks stop and people are waiting for unemployment to kick in and things like that, they become food insecure. A lot of us don't realize that we're all pretty much one check away from being food insecure. And then to combat that, we had grocery stores running out of food, grocery stores limiting food, and it really scared people. So we made at the food bank a drive-through pantry where we also made it a very safe area for our elderly to come, so they didn't have to get out of their car, they didn't have to go to grocery stores. And we put about 60, 65 pounds of food into each car in their trunk. So we never had to have face-to-face contact with them. And it worked really well. Comparing to last year's stats to this year's stats, we did over 600,000 pounds more than we did last year in a month's time. So it was a really great experience. Can I have the next slide? You can see that our area, some of the things that we suffer with that some other food banks don't, is we have a high population that does not have access to a working vehicle. They live in a food desert, so they're away from a grocery store. And then when you don't have a working vehicle, it also makes it very difficult for us to get food into those areas. You know, we're very fortunate because we're able to meet the increased need. We're able to get this food out, but we've had to come up with very creative ideas of how to get this food out. Today alone, we sent over 680 boxes of produce into Pickens, Lamar, and Fayette County. And we have plans for the rest of that, the rest of the counties this week. The need that I see that is coming up, I don't think people are going to get back on their feet as quickly as possible. People who had savings have spent it. People who had to rely on outside sources to get food have pretty much exhausted that. And many people who are living in these poor communities, in these outlying rural communities, they don't have access to healthy foods. They're getting their food at Dollar General, they're getting their food at little convenience stores because that's what they can get to, but it doesn't really provide the healthy options that, especially with the American Heart Association, you know, we really want to have people eat healthy. So being able to take in those healthy items such as fresh dairy, fresh produce, low salt, low sugar options, we've been able to increase the value for those families. The one thing I can see positive about this COVID, if nothing else, I think it's put on people's minds that food security can happen to some people. When you're a hairdresser and you're making good money and you're running your own business, you really don't think about that. But then all of a sudden you've had to stop your work, stop your paycheck, stop everything that you know. And it's really brought that to the foremost. So I'm hoping that people will now change their opinion. They'll start reaching out and they'll start thinking of people being food insecure, not just during holidays, but really at all time. And that's it. Thank you.
Hey, Jean, that was terrific. Great job you're doing there. Good insights as well. Now we welcome Brock Slebach to discuss how economics are impacting healthcare in rural and Appalachian communities. Brock?
Good morning, Darby, and thank you very much for the introduction and the invitation to be with you all today. If you'll proceed to the first slide, please. The next one. And one more. So as we've heard so eloquently expressed in Logan and Jean's presentations, we are working with disparities that do impact vulnerable populations that live largely in rural communities. As I always say in my presentations, we have a lot of old folks, poor folks, and sick folks. And so these are the conditions under which we're dealing with in our association and its work. Disproportionate share of people over the age of 65. We have a lot more veterans per population than our urban counterparts. Childhood poverty is higher. The rates of diabetes and premature death are higher. And at the same time that these conditions exist, we see that we have less access to primary care providers, oral health providers, and mental health providers, as you see there on the bottom part of the screen. Next slide, please. And when we look at the prevalence of Medicare patients with 6 or more chronic conditions, I think this tells the story of the rural South and Appalachia regions of our country. It's hard to imagine what it would be like to have 6 chronic diseases, but we have a large number of patients in our communities. So this presents a challenge for which the American Heart Association is doing a terrific job trying to bring a light to. And that is that chronic care is often much more complex care, and it requires a certain set of skills and services that are required to be able to provide the services that these communities need. And when you look at this map, you see the rural areas of our country are really disproportionately impacted by this problem. Next slide, please. And as Jean so eloquently discussed the issue of food insecurity, and I always overlay this map with the one I just previously showed you. If you look at the rates of chronic conditions in the previous slide and overlay the food insecurity regions of the country, you can see literally you are what you eat. And I think that we can see the impacts of chronic disease through the lens of enrollment in supplemental nutritional assistance programs that the United States Department of Agriculture is providing to our citizens. This is a map of the counties and the concentrations of those receiving SNAP benefits as a percentage of the total population in their county. Next slide. This all combines to create a convergence of pressure points that our rural providers, both clinics, hospitals, these are the elements of our communities, such as long-term care facilities, et cetera. And so all of these issues that you see circled around the core of our provider base in rural America, you can see all impact the ability of the providers to be able to do their jobs effectively. Next slide. When we look at some of the data, it's important to understand the nature of the services that are being provided. So why do I focus on rural hospitals? Well, rural hospitals in most of our communities are the organizing principle for healthcare in terms of recruitment and retention of providers. In fact, if you look around the country, you'll know that many rural hospitals are actually the employer of their physicians, nurse practitioners, and physician assistants. When the hospital goes away, so will the primary care workforce that's so crucial to address the issues I just talked about. So here you'll see 76% of the revenue generated in a rural hospital is on an outpatient basis. Next slide. You'll see here then when we look at the operational environment of a rural hospital, the average rural hospital in the United States, both a critical access hospital or a rural PPS hospital, has 33 days average cash on hand. That's a significant number in terms of its ability to withstand a pressure or a hard, stiff wind coming along, such as COVID-19. And if you look at the Appalachian states and the rural southern states, you can see that the number, those states being more darkly colored, represents less number of days of cash on hand than 33. So if you look at Oklahoma, Arkansas, Tennessee, Virginia, Mississippi, Alabama, you can see that they have between 0 to 19 or 20 to 39 days to finish. Next slide. And then this, of course, then impacts the operating margins of our hospitals. And look at the map and the distribution here. 48% of all rural hospitals today have a negative operating margin, and this is distributed in this graphic by state. So you can see that Kansas and Alabama are the two states that have the highest rates of hospitals losing money. In fact, the Kansas, my home state where I'm talking to you from now, has 86% of its rural hospitals losing money on operations. Next slide. And when we look at the vulnerability by number, our data partners at Chartis Ivantage Health Analytics looked at the hospitals in rural America and discovered that there are 453 that we classify as vulnerable to closure based on performance levels which were similar to rural hospitals at the time of their closure. Now, out of that 453, you'll see that 216 are considered most vulnerable before Corona. So this was before the outbreak of Corona and the public health emergency that was declared on March 13th. And here you see a breakdown of the style of hospital. And it's interesting that 119 of the 216 on the list are actually PPS hospitals or larger rural hospitals without special payment protections. I will also correlate another statistic, which is, I think, interesting. 75% of the hospitals that are considered vulnerable to closure are in states that have not expanded Medicaid for their residents in their state. Next slide. And when we distribute the hospitals that are vulnerable to closure, we see, again, where the concentration of those hospitals are. You can look along the southern states, and you can see the darker colors indicates a higher percentage of hospitals that are considered ripe for closure in those states. Next slide, please. So now what happened then after Corona, which is where the period of March 13th transcended us into a new period of history. Next slide, please. You'll see here that, as Logan had said in his presentation earlier about the spread of COVID in rural communities, so far 12 rural hospitals have closed in 2020, and 4 of those have actually closed since the declaration of the public health emergency in March. COVID-19 is actually growing faster in rural America in both number of cases and deaths, and that's according to the Kaiser Family Foundation. And as of May 26, there have been over 120,000 confirmed cases of COVID and 4,500 deaths in non-metro counties in the US. The latest and highest concentration per 100,000 of COVID infection is in Western Kansas and in Western Oklahoma. In fact, if you look at the rates per 100,000 for this population in Western Kansas and Western Oklahoma, It's 1,000 more per 100,000 rates of infection more than New York City. So we have basically higher concentrations of COVID in certain places around the country. One of the things that happened since we've had the shutdown of non-emergent and elective procedures, you can see that emergency room visits were down 42% nationwide since the public health emergency was declared in March. And if you look at the characteristics of the rural hotspots around the United States, you'll see that they are largely concentrated in rural areas that can have prisons, meat packing plants, and then long-term care facilities. Both congregate homes and nursing homes are definitely parts of the concentrations of spread of coronavirus. Next slide, please. In fact, this slide I did include shows and hopefully you're able to distinguish the colors between blue and green on your screen. The green trend line that goes up to 3,455 is Western Kansas and Oklahoma. If you look at the next highest line of 2,544 of COVID cases per 100,000, that's New York City. So the rate is almost 1,000 cases per 100,000 more in Western Kansas and Oklahoma than in New York City, and the tremendous problems that they encountered in the recent outbreaks. Next slide. So what we've seen, and drawing down now to a conclusion, is that the fractures that already existed in rural America regarding disparities, regarding the issues of low provider problem, low workforce issues, technology, and reimbursement, COVID-19 has beautifully, in a way, exploited those weaknesses and has really highlighted the fragility of rural healthcare. And so we see in these hotspots where we had outbreaks, there are some significant challenges to the rural providers there. And of course, what we've seen over the last couple of months and then highlighted in the tensions over the last several weeks regarding health equity, we see that the COVID disease in rural communities has been disproportionately impacting African American and Hispanic background individuals in these rural communities. And so this is another large area of concern that we're dealing with in this issue. Then we have a large number of rural hospitals and communities that really had no outbreak at all. The pandemic was issued in March. Elective services, non-emergency services were discontinued. And so we had all kinds of hospitals and clinics that were sitting and hemorrhaging cash because they had no business in their facilities. Next slide. So what's happened in the COVID-19 response at NRHA and in rural areas? Next slide, please. So here's a listing of the items that we've been working on. We have our resource center that this is a live link to if you have access to this slide set. We've been partnering with federal agencies to clear regulatory barriers for rural providers and discover resources that are available to help them. We have been providing technical assistance to rural providers of care on CMS conditions of participation waivers, which there were many. We had a membership listserv that generated thousands of entries from rural providers of care regarding all of the many things that were coming out daily that had to be tended to. And we learned a lot at NRHA through this best practice sharing and through the problem solving that was being done online. And we wanted to position ourselves as a trusted source of evidence-based information in a time of crisis that we were all facing. So advocacy on crisis funding through the public health emergency, and mostly we wanted to ensure a rural fair share as a percentage of all the resources that were coming out of Washington. Next slide, please. So in summary, NRHA was very successful. One of our strong successes was the $10 billion allocation for rural providers that went to rural hospitals, rural health clinics, and federally qualified health centers. We were very pleased that that cash assistance went out to them, and that has been very helpful in bolstering these facilities for the short term. Now we're working in the longer term to try to see how we're going to address these many problems and turn this into, as was mentioned earlier, never wasting the opportunity of a crisis to make more longer term change for rural providers. And with that, I'll turn it back over to you, Darby, and thank you for this opportunity.
Great, Brock. Appreciate those great insights and great activities that you've given us there. I want to turn now to Jeremy Beauchamp, Executive Vice President, American Heart Association, Southeast Region. Jeremy, thanks for joining us today.
Darby, thanks so much to you, and thanks to the whole panel. It's been very enlightening. You know, the Southeast region of the Heart Association, more than 40% of the population live outside metro areas. So the impact of COVID-19 in rural America is of great concern to us. You know, we saw recently the CEO of Ballad Health, which has health services in Tennessee and Virginia, said that they went from having 2,400 telehealth visits all of last year to having 15,000 just in the past 3 months. So relaxed requirements have helped make that possible. And it really is expected to be the future of health in rural America. Although, you know, clearly we have to address the broadband issues that we heard about today. So a lot of work to do there. In addition, you know, we've seen that telehealth increase, but we've also seen an alarming decrease in the calls to 911 since the onset of COVID-19. And as a result of that, and as you just heard from Brock, you know, hospitals are seeing a significant decrease in the number of heart attacks and strokes. But we know that heart attacks and strokes don't stop for COVID. We need to ensure that people get the treatment that they need. And as we know, you know, if you're having a heart attack or a stroke, time is everything. When it comes to getting treatment, the faster you get treatment, the better, for sure. So because of this, the Heart Association now has stepped up and is introducing our Don't Die of Doubt campaign. This is our hospital trust initiative to help communities learn to overcome their fears of going to the hospital during this very unusual time for our world. The campaign reinforces the insight that hospitals are the safest place to be in the event of emergency. That hasn't changed. If you're having a heart attack or a stroke, the place that you need to be is the hospital. So we'll be sending more information out to all the participants in an email following up today's call. And we're excited for you to learn more about our Don't Die of Doubt campaign as we move forward. So I want to just thank all of you for joining the call today and being part of this initiative. We know that it's really important that everyone, no matter who they are or where they live, have the access to high quality healthcare, and we appreciate your support in that. So Darby, let me just turn it back over to you, and thanks so much for the opportunity to share a few thoughts.
Thanks, Jeremy. I think we're going to go right on to April Dawn for a Q&A. April Dawn for a Q&A.
That's right. Thanks, Darby, and thanks, Jeremy. Anyone that would like to ask a question, you can use the Q&A feature that you see in Zoom. You can type your question into that box, and we will be happy to try to get to as many as we can today. In the meantime, we have a few questions we received as part of our registration process. Logan, I'm going to turn to you first. Knowing that unemployment is at an all-time high and the ability to hire has lessened for many, in what other ways can we help the economy in these communities that are hardest hit?
That's a great question. I think for organizations such as ARC that provide funding to these communities, we've become a lot more flexible in the types of programs that we're funding, and also for existing programs, if they're not able to meet deadlines or they need adjustments to the scope of work, to the timeline, that we're being flexible and understanding there. You know, I think that's key throughout kind of all sorts of economic transactions, whether it's between renters and landlords, having some type of understanding there, and whether that's provided through stimulus from the government or regulations for the government. I'm not sure what the best way of going about all those is, but I think just kind of we have seen it so far, just kind of an understanding of this is an unprecedented event that really no one could have prepared for, and we're working that into how we do operations. So we're not sticking to, something needed to be done by May 1st when that was just not possible. So we're being increasing flexibility. So I think service providers have that possibility. So that's one. I'm not sure how much I can delve into kind of the fiscal idea and what Congress should do. That's really not my position, but I think we may have seen, based on the most recent jobs report, that kind of the stimulus they provided and the Paycheck Protection Program worked. And so at some point, maybe that's worth revisiting if something like that is needed in the future. I'm not saying it is or it isn't, but that's another obviously huge variable moving forward here.
Thank you so much. And Jean, do you see any long-lasting changes? I think you touched on this a bit, coming to your organization as a result of the pandemic, things that will be sort of irrevocably altered?
I think you're going to have your people who are going to experience long-term food insecurity. I think people are going to change their buying habits. Unfortunately, when money gets tight, they start buying more unhealthy foods because they're usually cheaper. And that always concerns us, because then their health problems are going to go up, and it's kind of sometimes puts them on a hamster wheel of one problem starts happening, another problem starts happening. We recognize that, food insecurity, especially now, doesn't fall along a poverty level. And I think this showed it more than ever. But I think it's going to take a long time for people to get back into the job, back to build up their incomes, back to build up their safety nets if they had them. And I really think it's going to change the way people perceive food and their access to food.
And let me ask a follow-up there, Jean. If folks today, as a takeaway, are thinking of one thing that they can do to help address food insecurity, what would that one thing be for you? What's primary?
Primary is getting funds to, people don't realize food banks buy a lot of food. It's not just donated food. We have to spend a large part of our budget buying food. So donating to a food bank, we can always buy food at a much cheaper cost, and somebody can go to the grocery store, buy it, and donate it to us. But also to be aware and recognize if somebody in your community, in your neighborhood, in your family is food insecure. I think a lot of people don't recognize the signs. We always ask pediatricians to screen for food insecurity. We ask seniors, senior centers, senior social workers to always screen for food insecurity. And a lot of medications require certain foods or are banned certain foods to eat. And so we always try to bring that discussion into the conversation of food insecurity.
Thanks, Jean. And Brock, turning to you, sort of a similar question. We know the pandemic has heightened challenges with access to care. What are the best ways that we can all support the healthcare delivery system for those who are staying home in the most vulnerable communities?
Well, I think that obviously, as was mentioned by Jeremy, the access to telehealth is important. Making sure that you reach out to your provider if you have a concern or a problem, and don't be afraid to do that. If there's a way to connect online, I know some of our providers have been extremely innovative and are actually sending certified nurse assistants or community health workers out into the field with iPads to connect people who don't have that technology in their home to be able to do that to the clinic. So those are the kinds of innovative things that I think that are really critical. And then, as was mentioned, don't be afraid to go to the hospital if you need to. And I think that delayed care is bad care, and because it just delays the ability for the condition to be treated early and to potentially avoid a lot of harm. And I think that's a big message that we need to really underscore for people living in rural communities.
Thank you. Logan, turning back to you for a minute, can you talk a little bit about what you see in terms of business response to this, closures, future plans, how that's sort of impacting the picture overall?
Sure. I saw a survey released. It was a working paper at NBER if anyone wants to take a look, and they surveyed small businesses in, I believe, April, and I think they found that something like 2% of small businesses had closed in America. So it's a small percentage, but you think if there's 5 million small businesses, and so that's equal to about, what is that, 100,000 small businesses. So we have seen significant closures already, and I think in that same survey, something like 40% of businesses said, well, if the pandemic lasts 4 months, they don't plan on being open at the end of the year. So whether that remains to be seen, that's more of a kind of a forecast on their part. So whether that doesn't take into account, again, any type of stimulus that may come into the picture, any type of monetary response in terms of lending. But I think also kind of touching on what Brock was talking about with the hospitals and having so much cash on hand to last a certain number of days. I believe that survey, I can pull it up real quick actually. The median business had more than 10,000 in monthly expenses and less than 1 month of cash on hand. So similar to the numbers with the hospital, slightly lower in terms of the number, but in terms of the amount of cash on hand to survive. So it's really a really tough environment right now. Obviously, it goes without saying for small businesses, and so I think we're, service providers such as ARC, we're doing as much as we can. But obviously we can't do everything. So other types of organizations have to step up as well and be flexible and provide types of funding that maybe they otherwise wouldn't in normal circumstances. I hope that answered the question a little bit anyway.
That does. Thank you so much. Thank you to all of our panelists, not just for your overall insights today, but for your openness to these terrific questions that we received from our registrants prior. Now it's really my honor to turn things back over to Darby, a longtime volunteer, who will really talk from a volunteer perspective about the passion points he sees and how we can all take action together to benefit folks in our most vulnerable communities. Darby?
Thank you, April. And that was a great discussion. Thank you, panelists all, for your answers and insights and presentations today. We're all passionate about the health and well-being in rural and Appalachian communities, and the pandemic that has just gone through has, or we're still in, I guess, has demonstrated how some of these issues create vulnerability in these populations. So we appreciate all the volunteers and staff who attend to this issue. And then we're going to send all of you several resources and calls to action via email following today's meeting. We're going to ask you to join the You're the Cure network. This is our grassroots advocacy network, which will allow you to learn about key issues impacting your community and take action if desired. Details will be set out on that following the meeting. Another is Empowered to Serve applications. We're calling on social entrepreneurs nationwide to apply for the Empowered to Serve Business Accelerator Financial Grant Awards to help improve underlying health conditions in underserved communities. Applicants provide proposed business solutions to specifically address and improve challenges presented by the social determinants of health, the social and economic conditions in which people are born, live, learn, work, and play in historically excluded communities. Now through June 30th, 2020, interested entrepreneurs may apply to the grant program at the empoweredtoserve.org/accelerator. We'll send a link with more information and that link as well following the meeting. And lastly, take part in the follow-up survey to today's meeting. You'll receive that via email. this will give AHA staff an opportunity to connect with you if you'd like, and volunteers like me to deepen our networks within AHA. We'll give you the chance to get regular AHA updates on Appalachian and rural health. And we hope you will participate in those tools and opportunities. And with that, I'd like to welcome Kevin Harker, the EVP of the American Heart Association Midwest region, who will take us home and will offer concluding thoughts today. Kevin.
Hey, thank you so much, Darby. And I want to say a special thank you to certainly Brock and Jean and Logan and my colleagues, Jeremy and Nicole, for their great words and for their leadership in this effort. I've worked for the Heart Association for about 32 years. And in those 32 years, rural health has always been a priority for me. The reason why is because I grew up in a town of about 800 people in Kansas. I had 36 in my graduating class. The hospital serving our community was about 15 miles away and had 18 beds. And so when we think about health disparities, I certainly think about our inner cities and the challenges facing those inner cities. But I also think about our smallest communities. Those are my people in many ways. My hometown, certainly the Native American populations that are facing tremendous health challenges, and also the Appalachian region, which we've been focusing on today. Those are individuals that are counting on us, that are counting on you. And I want to say thank you for joining us today, and also for your leadership, for your passion, and for your dedication to these important segments of our population. So thank you for joining us. We're so grateful for your support. Be well, and thank you all once again.